All right, guys, good morning. My name is Rush, one of the fourth years. If you guys don't know me already, I know where you've been for the last few months. My presentation is on quality improvement paradigm and models. A quick shout out and thank you to Drs. Mehta, Dilip, and Chan for helping me with this lecture. All right, so just a quick review of what we're gonna be going over today. We'll go over some of the basics of what quality improvement is. We'll go over some models that are frequently used in healthcare to implement change. We'll look at the tools in our toolbox, things that can help us use and implement the models for change. Last, we'll go through an example. The last example is going to require resident involvement, so I will pick on people ruthlessly. And let's get started. So let's go with the basics. What is quality improvement? Simply, it's a framework that we use to systematically improve the ways of delivering care to our patients. This is meant to help the patients, to help the outcomes, to improve the system that we're working in, and also to help ourselves work in a better environment to make ourselves also less burnt out. The Institute of Medicine has identified 6 domains. Let me see where do I click. It's identified 6 domains under which we can put quality improvement buckets under. And so if you're looking to improve anything within a system, you're effectively judging the system based on these 6 different buckets, whether something safe, effective, patient-centered, timely, efficient, equitable. And so then why does this matter? Well, for one, we deal with this every day at work. You'll often realize that you're dealing with a system that maybe isn't as efficient as you want it to be. Maybe something isn't working the way you want it to be, and that you don't like the way that things are being run. For example, you're running a year into the stat lab. Secondly, it's something we had to deal with during our time in residency. This is my one plug as chief for you guys. Page 133 of the handbook. You had to finish a QI project before you graduate. Think about it before the end of your intern year. It's due by your 4th year. So make sure you're thinking about it. It doesn't sneak up on you when you're doing your research elective. And lastly, something that we're going to deal with during our careers, whether directly or indirectly, whether there's a QI project happening around you and you had to change the way that you're functioning in your work environment, or whether you're dealing with a QI project yourself. On top of this, CMS has started implementing reimbursement to metrics. And so as a result of this, more departments are looking to implement QI changes to make sure that they're not losing any possible revenue. Lastly, there's this idea of the parallels between quality improvement and evidence-based medicine. The idea of evidence-based medicine is about doing the right thing for the patient. We want to make sure that we're doing ordering the right labs, doing the right imaging, and also giving the patient the right medications, or not giving them if they're not indicated. In a similar fashion, quality improvement is about doing things right for the patient. We may know that we're doing the right thing. We may know that giving antibiotics to patients with sepsis is important, but are we also doing it in the most effective way? Are most patients getting the medications within the first hour, or are they getting the aspirin within the time frame for patients coming with chest pain? And so this idea of quality improvement, evidence-based medicine goes hand in hand with this idea of doing the right thing the right way for the patient.
I just want to add on to, I don't know if the residents know this, but it's also part of your continuing board certification. You actually have to show that you've done a QI project as a faculty as well. So to be board certified.
So Dr. Willis just mentioned that it's part of your continuing board certification as attending. So in your future career is something that you do need to keep in mind as well. And so going with some of the principles of quality improvement. The first one is it looks at the system and processes as a whole. It focuses on the patients and the members of healthcare providers, the nurses, the techs, et cetera. It looks at being part of a team. It's not just one individual functioning within the system, but rather how the different parts interconnect. And lastly, and most importantly, it looks at the data. You are using data to help you drive changes. Just a couple of important historical figures. This is W. Edwards Deming. He was a statistician engineer. He was basically the father of quality improvement, worked with manufacturing in the early 1900s. And then afterwards, Don Berwick, who's a pediatrician, who also decided to use models and science of quality improvement and brought them over to healthcare. He ended up being the leader for CMS, and he also came to co-found the IHI, the Institute of Healthcare for Improvement. I'm not going to get too much in the details of this. This is sort of the terminology that you'll often see with quality improvement. So quality improvement, like we talked about, is a framework that we use to improve care. Quality assurance is basically making sure that the care, the quality of your say you're giving is up to par. process improvement is looking at the way that things are run and improving that process. And the process measure is a way of measuring that process so that you know that if you change something, how does that impact a specific metric, for example, time. Outcome measure is looking at the big picture and trying to figure out what the outcome is that you're worried about and measuring that. Lastly, balancing measure. This is sort of the unintended consequence. If you implement change or recommend something, you might have an improvement in one area, but you might have a negative impact somewhere else. You may improve the turnaround time for CAT scan, but you may have more patients having ordered unnecessary creatinines and blood work. So let's look at the basic general steps of how do we implement a QI project. Well, the first one is you got to identify the issue. You got to know what you're trying to improve before you can improve it, right? The second is this idea of an aim statement. It's basically the goal. It's a clear, explicit summary of what your team hopes they will achieve over a specific amount of time and the magnitude of change. And then you look at the current situation. So this is usually data-driven. You might find sort of the metrics that you want to assess and analyze them. And then you'll plan to change. You'll consider a few hypotheses and say, maybe this isn't working efficiently, and so maybe we can change one part of the system. You'll implement that change. And afterwards, you'll analyze it. And lastly, and most importantly, you'll reassess. You'll go back and say, okay, did this process work, not work? And you go back to start. And it's going to be a iterative process. This is something I'm going to talk about more in a few minutes. So there's a handful of quality improvement models that exist out there. Like I said, a few of them, especially the Lean model and Six Sigma, which you may have heard in life, these were created for the manufacturing industry. And they are used in healthcare, but the one that's used most often for us is the model for improvement. W. Deming, the person I mentioned before, his approach to this was saying that there's a lot of variation in any system, and the more variation there is, the more waste there is as a result of this. And so his approach to these Creo models is to reduce the variation, which leads to reduce waste. It kind of makes sense. You want to make sure that the two different things going to the same system have the same output. But if there's variation, then maybe person A may have a different outcome than person B. If there's a lot of variation, increased length of time from when the labs come back, increased time from when the consultants respond back to you, from when the meds are given. And so by reducing this variation, you want to make sure that patients hopefully have the optimal outcome. So this is the most important model that is used for quality improvement. It's a model for improvement. It focuses on the healthcare system as a whole. It looks at the system and the organization, and not the individual that works within that system. And it focuses around answering these three basic questions. The first one is, what are we trying to accomplish? By answering this question, you're going to create an aim statement, like we mentioned before. It's a specific statement that helps you say you're going to achieve an improvement in one specific metric over a magnitude over a specific amount of time. So for example, we might want to decrease eating length of stay by 1 hour over the next 6 months. The second part is, how will we know this is a change in improvement? So this is forcing you to create, think about the metric that you're going to track pre and post intervention. And lastly, the question is, what change can we make that will result in improvement? And this is when we start brainstorming the hypotheses and sort of the different ideas and plans you can implement throughout. And this leads to the PDSA cycle, which if you haven't heard about already, you'll definitely hear about in your career with quality improvement. So by answering these three different questions, it sets you up for starting the first part of the, where am I on this? The first part of the cycle, which is P, the planning. So you've planned, you have a team, you've looked at the data, you've figured out what you're trying to accomplish, and then you implement the change. And that leads you to D, the doing part. You implement the change, you wait a few weeks or months, and then you look at the results afterwards, and you say, okay, did my change have any significant impact on, let's just say, ED length of stay here? Did it improve, did we improve it? Was it flat, or did it go down, or did it get worse, sorry. And afterwards, you go back to the start. You say, okay, I've had this one change, and if it worked, good, but let's go back and see if there's anything else that we can improve. The whole purpose of quality improvement, and especially this PDSA cycle, are small incremental changes. It's not one big sweeping change that's going to magically fix the system. It's a fine tuning over many months, over many years, to sort of lifetime. It's a way of thinking and a way of approaching system to ultimately achieve what we hope is the best system for our patients to be patients in. The next model is a lean model. And like I mentioned before, this is created in manufacturing. This looks at its customer-based model, and it says, what matters to the customer at the end of the day? What do they care about? And the whole point of this model is to remove all the waste. And the waste is broken down into 7 different buckets. Where am I here? So transport, inventory, motion, et cetera, et cetera. And basically, it looks at all the things that matter to the customer and cuts down everything else. And so hopefully by going through this, you find what matters, you look at all the different components that the customer experiences and maybe what they don't experience. And by reducing all the things that don't matter to the customer, aka our patient, we can have a better outcome or better experience for them. This isn't used as often in healthcare, but something that you'll often hear about and is used in some aspects of healthcare, something to be aware of. Next, and similar model is Six Sigma. And this was created around the idea of reducing waste. And so it's really a statistical and analytical based approach for a system. I won't go too much into detail here. I will say that this model is Six Sigma and the previous model, Lean model, are often combined into Lean Six Sigma. That's something that you might hear about. And the basic concept is you're trying to improve the value for the customer by decreasing waste and also cutting out a lot of the unnecessary fat and using a statistical approach to this. There are a lot of different other models out there, whether you're looking at community health, population health, or other components. It helps you identify the different components in a larger system and helps you sort of plan your approach for implementing change. So now that we've chosen a model, typically for us it will be the PDSA and the Institute of Medicine model, the model for improvement. You want to use a toolkit, and these different tools will help you basically implement whatever change or hypothesis that you're looking at. There's quite a few of them out there. I'm only going to highlight a few as outlined here. The Institute of Health has a great PDF online that's available for free. And there's more options there. This is where I got most of my information from, and it's really helpful and really concise and really easy to understand. First one's the cause and effect diagram. Basically, you look at the effect, and maybe you're concerned about long test results time. And then you start looking at what are all the different causes of that. And you look at sort of different components, the environment, the people, the equipment, etc. And then you break down even further. And this helps you really understand in granular detail the different components that lead to a specific effect. And through this, hopefully, you can create a hypothesis. Next is a driver diagram. It's sort of similar in nature. It looks at the goal they're trying to achieve. And so here might be to decrease MRSA colonization. And then you might look at specific different factors that contribute towards that specific goal. You look at secondary factors or secondary drivers. And then through this, you can start brainstorming different hypotheses that might affect the secondary drivers, which will in turn ultimately affect your aim. And hopefully you can find small hypotheses and changes that will lead to a better improvement in your healthcare system. Next one is the failure modes and effects analysis. This one's a little bit more in detail. It's I'm not going to go too much into today. It's a very statistical way of approaching a problem. In brief, you look at the current system that you have and helps you anticipate things that can go wrong. You list all the things that may go wrong. You list the severity of impact if it goes wrong. You list the chances of you catching that of that one thing if it goes wrong, then the impact of it. And then if you multiply these numbers together, something that has a high number means it's high chance of going wrong, high chance of it being undetected, high chance of having a bad impact. And so that's probably the first thing you want to change in a system. This is sort of an example. It's sort of hard to read, but like I said, the IHA has a great PDF that goes through it a little bit more detail. Next is a flowchart. You guys have probably seen this before. It's a process map. It's a representation of how one part in a system experiences that system. For example, how a patient experiences triaging. And this will help you look at the process and understand how that one part experiences the process. You can maybe look at areas of weakness or areas for growth. Second to last here, next is the Pareto chart. This looks at if you have something that's often going wrong, something that often has areas where it's always down, for example, maybe a lab machine is always working, you might say, why is it not working? And after you collect data, you'll say, okay, this is the most frequent reason and this is the least frequent reason. And through this, you can create a chart and you can sort of focus your targets on improving the sort of useful many as opposed to working on the things that are less likely to contribute towards that the error. And so it helps you sort of bucket the things that will help you focus your energy at the end of the day. Lastly, it's a run chart or it's a control chart. And this is basically a way of plotting data over time, and you can sort of compare information pre and post intervention, and it will help you see whether the change was impactful or not. Sort of in summary here. So at the end of the day, you will choose a model for how you want to approach quality improvement project. It's one of the ones on the left, right? And for us, it's usually the model for improvement, the PDSA cycle. And with this, you can use a variety of different tools on the right and then help you implement that small change in that system. So let's go through a case. And this is where I want resident and attendees want to jump into. That's great, attending involvement. So your hospital has been found to have a higher than average lab turnaround time of 6 hours. Delays have poor patient outcomes, decreased patient satisfaction, increased length of stay, and more patients walking out the door. So you're tasked with addressing this issue. What do you guys want to do? So let's start with the framework, right? We want to identify the issue. Anybody in Zoom or anybody here want to identify what the issue is? Yeah, great. So labs are taking 6 hours, and as a result, we're having negative impact on our patient care. Good. So who wants to create an aim statement? Maybe a statement of what we want to achieve after our care project is done.
Reduce it to 1 or 2 hours instead of 6.
Great. And so we want to reduce by what I mentioned specifically specific amounts, so by 1 or 2 hours. And then we can add in over a specific time frame. So let's just say we want to reduce it by 20% over 6 months, right? Good. So now we want to evaluate the current situation. What are different ways that we could look at the current situation and better understand maybe why the labs are taking so long to come back? What's one of the tools in our toolkits that we might have that I might have mentioned that would be helpful here? Great, yeah, that's the cause and effect, or the Fishbone diagram that Sophia just correctly mentioned. And so now we mapped out, the lab results and all the different components, and we've identified all the important factors in this, right? Next, we plan a change. And so this, depends upon, the system that you're working in. You might say the lab machine is often down. And so maybe you want to invest in a new one because that's contributing towards frequent delays, or we don't have enough staffing. But with this, we've done the planning, and now we implement, say, let's implement a change, and we move from the planning to the doing. And so then we implement the change. So let's say for us in our hospital where we aren't putting emergency labels. And so all our labels or our labs are seen the same as the floor. Now we label them differently and look at the change. And hopefully we might see an improvement in our outcome. And then we go back to the start. As I've mentioned a couple times here, and I want to emphasize once more, the whole thing is a iterative process. Once you have a change or improvement, it doesn't mean you stop there. It means you go back from the start and you fine tune. And hopefully you achieve a place where you have the optimal system, but it doesn't mean that you stop there.
I think some things that were implied, but communication is if the lab takes too long, it's not going to be productive. And then for the aim statement, when you're trying to plan what the goal is, I think using standardized data or national data is helpful to kind of make a benchmark. If you want to arbitrarily say, hey, you want to do this amount, you want to try to bring yourself closer to what is expected, or maybe what's dictated by that.
Great, and just to reiterate for people on Zoom, so Dr. Willis just mentioned, one of the things that we want to make sure that we're keeping in focus is the patients, right? And so the lab's taking quite a while. It doesn't matter so much, but it starts to matter more when it starts having a negative impact on our patients. So we want to keep our patients in mind and make sure that the changes we're implementing are patient-focused and patient-oriented. And the second component being, you can use national metrics and benchmarks sort of as your as a way to compare how you're running as opposed to somewhere else, as opposed to having sort of blind goal. So in summary, quantum improvement helps us do things the right way, and then in conjunction with evidence-based medicine helps us do the right things the right way. Helps us use a systematic approach to identify and address changes in an incremental way as opposed to broad sweeping changes. You can use the tools in your toolkit to understand and analyze the systems that you work in. And as always, it's reiterative and a constantly evolving process. Any questions? Dr. Casey?
That was great. I think that it's extremely important, as you said, we all have to be involved in this. So a couple of points that I would make are make sure you have good data, right? So it's like a research project. You know, poor data in is poor data out. And the other thing is people. It's the most important aspect is to get everybody on board. And when you look at what Toyota did in the car making industry, they thought that the most important item in that was the employee, the person on the line. So they literally developed, you know, the conveyor belt and all the tools are right here so that that employee didn't have to move. Everything was moving towards that employee. They did their job and then it sort of went on. So without buy-in by the rank and file, the best systems in the world won't work. So the other part with any kind of continuous quality improvement project is to get buy-in from the actual people on the ground and to reward them for good performance. Because when everybody's on board, just like Toyota, it really is very successful no matter what you're doing. Deming is great stuff if you read it, some of the things that he wrote, mostly initially with the automobile industry.
Yeah.
It really translates to healthcare very well. Excellent job. Thanks.
And just to reiterate, so Dr. Casey said there's two major points to keep in mind. One is you need good data. With bad data, you won't have any good or consistent, reliable outcomes. And the second part is having buy-in from everybody in your workplace. Without good buy-in, you won't have an impactful change.
Right. Are there real examples for quality improvement to patient outcomes? Is there any data?
Yes, there is. I can't say anything off the top of my head, but there have been changes. I mean, the question they're asking is, you know, are there changes that have been made in healthcare that lead to better outcomes? Yes. Is sepsis one of them? Probably not.
Stop sepsis campaign, right?
Oh, not at all.
Sure. Time to antibiotics, 1 hour. You know, the bundles. That has shown improvement. Even our own hospitals have shown some improvement to stop sepsis campaign. So I think there are, but that might just mean, you know, as Dr. Sinard's saying, that just might mean that we have to tweak the system a little bit better. But you don't blow up everything because you say that there's definite examples out there, but you just have to see why they work and then translate those into your own shop.
Right. And I think it's also very hospital dependent. You know, some hospitals might have weak points, other hospitals might not. And so, you know, for example, having quantum improvement of making sure you get EKG in less than 10 minutes for a patient comes with chest pain might be more important in one system as opposed to another.
Casey and Senator Brown, two very good points that they did this campaign for Stop Sepsis and it got better, but the second look around is what was important there because they realized It wasn't because what we changed got better, it's because people were actually looking at it that it got better. So doing the multiple rounds of checking and fixing and checking and fixing is really what's important, and not just making the single fix.
Great. Thank you, guys.